So good morning. I'm going to take you through some of the things that we do in interventional radiology. And we have a real identity crisis locally and nationally about what interventional radiology is. So I'm going to tell you some of the things that we do. I'm sure everyone recognizes this, and I think this is a good player to have on your team now. In terms of funding and research, I imagine that could be very helpful. So what is interventional radiology? Well, you can see here that we basically do procedures in a sterile environment using image guidance. So we do minimally invasive image-guided therapies. And we use different equipment. This is a fluoroscopy unit. It gives us real-time live x-rays, and we look at a monitor, and we can guide catheters and tubes and wires and different instruments, which I'll describe, into different parts of the body. We also use CAT scan to guide procedures. We can do ablative therapies, biopsies, all kinds of different types of procedures using the CAT scan guidance. And finally, we use ultrasound guidance daily to guide different procedures, and we'll get more into that later. Some of the diagnostic tools that we use, we have catheters, different shapes and sizes. Some of them are the size of spaghetti, and some of them are the size of linguine. It depends on what kind of blood vessels we have to navigate into. We use guide wires, which go inside of the catheter, and they can help steer us with different shapes through different catheters into different blood vessels to deliver different agents. Some of them chemotherapy, some of them contrast, and we'll get more into that also. In terms of what we put through these catheters, we put particles, which can help block up blood vessels that are abnormal, and we can also introduce different chemotherapies mixed with the particles or mixed with different agents. And I'm going to tell you a little bit about those different agents later. And we do ablative therapies where we can find a tumor, we can guide a probe, and there are different types of probes. There are probes with multiple tines. We can insert multiple probes into one different tumor. This is the liver. This is the tumor. We target the tumor using either CAT scan or ultrasound guidance, and we can ablate the tumors. So these neuroendocrine tumors are classified in different ways, and we're going to focus on a category in interventional radiology, but they can be classified embryologically as involving the foregut, the midgut, or the hindgut, and the midgut tumors are the ones that generally we work with. They can be functional or non-functional, and we basically help treat the functional ones. And they can be classified basically as gastroenteropancreatic neuroendocrine tumors, which are the purview of the interventional radiologist. This is a pie chart of the frequency of symptoms in carcinoid syndrome. I think we all know that the two most common symptoms are flushing and diarrhea, but there can be other symptoms like cardiac cramping, telangiectasias, wheezing, edema, cyanosis, and they make up a smaller part of the pie. This is just a little schematic. That's a zebra that's flushing. So in radiology, before you get to interventional radiology, you'll generally go through some imaging and some of the ways that we use to diagnose tumors. The least high-tech is the small bowel series. Really not a strong tool, but at times it can pick up these tumors. CAT scan can pick up the hypervascular liver metastases. We talked about the artery scan, and MRI, which is probably the study of choice for liver metastases. Here's an upper GI series. Basically, you drink that white stuff. This is an X-ray of the abdomen. This is the small intestine. The stomach's up here. And as you make your way through, the bowel should look uniformly white. And you can see here, this is a carcinoid tumor in the small bowel. And that filling defect, that disruption of that oral contrast helps identify that tumor. This is a CAT scan of a neuroendocrine tumor. And again, you can see this is an axial cut. The CAT scan takes slices from the top to the bottom. This is the front, this is the back, here's your spine. And you can see here this soft tissue, this sort of grayish tissue, that's the tumor. The picture next to it, that's our coronal image where it cuts from the front to the back. So it's going, so here's the top, here's your bottom, and you can see here this large soft tissue mixed density. This is some contrast mixed in with soft tissue. That's tumor. Up here is your liver, up there is your spleen, and this is a very powerful tool, the CAT scan. The Octria scan helps identify, that's the shotgun approach. We can look for tumor, see if it's metastasized, and what parts of the body. I think you get a sense that here's your head, feet are down here, here's your abdomen. And where you see those black spots, those are the lesions that we're looking for. And finally, the MRI. It looks similar to the CAT scan. It's better at identifying soft tissue tumors. This is the liver. Here's the aorta, and you can see all these black spots. These are multiple liver metastases from tumor that ends up in the liver. And the liver should look more uniform and homogeneous as it does up on that top image. It just is smoother. So this is very, very sensitive at picking up tumors in the liver. So neuroendocrine tumor management, our goal is to localize the tumor, remove the tumor, and control the symptoms. Treatment options for hepatic predominant disease, there's hepatic resection and liver transplantation. Those are the surgical options. And if there isn't a surgical option, then there's a chance of non-surgical liver directed therapies that may fall into the domain of the interventional radiologist. And we're going to talk about those. Now, the liver metastases are responsible for the majority of the morbidity and mortality related to this disease. And the alleviation of the symptoms and prolongation of survival are the main goals. So, in interventional radiology, the refractory, unresectable, or recurrent disease with hepatic predominance is our domain. And an aggressive approach to management increases survival time when less than 50% of the liver is involved. And the key is catching it before it gets too advanced. So here's multiple imaging studies that we can look at. This is a CAT scan. Again, not the best tool at looking at metastases, but certainly we pick them up every day like that. On the top image, you can see how subtle it is, but there's at the periphery, at the edge of that image, there's a liver metastasis surrounded. It's the gray on the inside and a little white on the outside. This is a little bit more advanced. There's multiple small liver tumors in that image. Here there's a very large dominant tumor. That's very advanced. It's taken up a large portion of the liver, as is the bottom image with multiple what we call cannonball type lesions throughout, multifocal diffuse disease throughout the liver. So what are some of the liver-directed therapies that we have in our arsenal? Probably the most studied, the best bang for your buck is going to be the hepatic artery embolization. We'll talk about different ways that we do this. There are ablative therapies, radiofrequency ablation and cryoablation. It's a way of basically killing tumor by either heating it or cooling it. At either extreme of the temperature spectrum, tissue is going to die, and we have ways of doing that. And finally, there's radioembolization. which we'll talk about near the end. So the goals of embolotherapy or embolic therapy, embolization, it should be tailored and patient-specific. The goal is to reduce tumor bulk, reduce hormone levels, palliate symptoms, and possibly even convert someone who is unresectable to a resection or transplant candidate. Hepatic artery embolization, it decreases hormone secretion, it provides symptomatic benefit. There's radiographic regression, there's 75% symptomatic improvement, and the duration of the response lasts anywhere from 4 months to 2 years. And it's something that can be performed several times, over and over. Patient selection, the indications are rapid enlargement of tumor mass, increasing symptoms of the tumor bulk, and patient preference. The criteria that we use radiographically and metabolically are whether it's radiographically appropriate to do, is the portal vein, one of the blood vessels in the liver. There's a hepatic artery and a portal vein, so the liver has 2 blood supplies. If you're going to knock out one of them, you should have the other one working. So we check that at the time of the angiogram. A bilirubin level of less than 3, an albumin greater than 2.8 milligrams per deciliter, and normal hematologic and renal function. These are things that we screen in order to identify patients that are good candidates for this procedure. There are different agents that we can use. There's something called bland embolization, where we inject particles that just go in the blood vessel and decrease the blood supply to the tumors, and that can result in symptom relief. As we've progressed, there are certain chemotherapy agents that we can add to the bland embolic agent, and I'm going to show you pictures of those. And talk a little bit more about the different chemotherapy agents that we use. So everyone knows what that is. That's just table sugar, but it doesn't look that dissimilar from some of the particles that we inject into the blood vessels to block up the blood supply to these tumors. And this is one of the agents that we use. When you mix the particles, which are the white, it looks like a snow globe. But basically all the white stuff in here is mixed with X-ray dye contrast that we inject using those real-time X-rays into the catheter, into the blood vessel that's feeding the tumor. And just that alone, without chemotherapy, will block up the blood vessel and the blood supply to the different tumors. But we can also mix those particles with different chemotherapies and possibly get more bang for the buck, because we can deliver much higher doses of chemotherapy in a catheter-directed fashion directly into the tumor blood supply, and not only get chemotherapy into the tumor, but also block up the blood supply at the same time. And that's called chemoembolization, or what we call chembo, chemotherapy and embolization. And basically by combining the two, we can treat different tumors. So how does this work? Well, you would come into the hospital the morning of the procedure. We have an anesthesiologist that would give you medicine through the IV, make you comfortable throughout. The procedures last anywhere from 1 hour or 2 hours. We would puncture the artery in the groin. We would thread a catheter up into the blood vessels that go to the liver. And we would inject X-ray dye and take pictures using that X-ray machine, the live fluoroscopy unit, and we would identify the different blood vessels that go to the liver and make sure that the portal vein was patent. Because if we block up the artery, we want to make sure that the liver has some other blood supply. We can selectively navigate these catheters now based on the technology that we have in catheter technology into different specific blood vessels that are feeding tumors, and I'll show you some pictures of that. And then we inject the embolic agent with or without a chemotherapy. So this is a schematic, and if this is the yellow is the tumor, the red is the blood supply, there's a white what we call a microcatheter that we can navigate very far out into the specific blood vessels feeding that tumor. Here's basically a broader picture, but this would be the artery in the groin that we would puncture with a needle. We would thread the catheter up to the arteries that go to the liver and navigate the blue catheter into the blood vessels that specifically go to the tumor and try and spare normal blood vessels that are in the liver of the embolization. And here are some of these particles that we would inject through these catheters to block up the blood vessels that go to the tumor. Any questions?
How about peri-procedural medication to avoid problems like carcinoid crisis?
Right, so we would give you medications to prevent any kind of carcinoid crisis. Somatostatin analogs are given, and throughout the procedure, you're monitored in our place by an anesthesiologist. So there's a high level of care that's delivered to prevent any crisis situation. Antibiotics are given as well. We give, I might have a slide on that, but we do give antibiotics before the procedure and during and after the procedure as well.
Is there pain involved?
There most likely is pain. I think we're seeing less and less pain as we're getting more and more super selective. And the embolization procedures, there's 100%, we used to say there's 100% post-embolization syndrome. So we would inject, basically, when you block up a blood vessel in any part of the body, it can result in pain. Patient that has a heart attack complains of chest pain, a blood vessel in the heart gets blocked up. If we block up a blood vessel in the liver, you're not having a heart attack, you're having a liver attack, and it can result in pain. It can result in pain and fever and nausea, and those things are managed in the hospital with medications. And we've trended towards less and less of this post-embolization syndrome as the technology, the beads and the particles and the microcatheters have gotten better and better.
Do you ever use catheters with balloons on them to prevent the flow of your thing into other branches?
It's not something that we have to do anymore because we're so super selective, because we can get so far out. Let me just show you here. We used to do what was called lobar embolization. So if there were tumors throughout, you have a right arm and a left arm and a right leg and a left leg, we have a right liver and a left liver. So historically we would do lobar. We would basically shotgun the whole right hepatic artery and embolize the whole thing because there were multiple tumors. We tend to be able to, depending on how extensive the hepatic disease is, we can specifically navigate different catheters. So historically, we might have put a catheter here because of what tools we had and embolize this whole thing. Even though these are normal arteries, this is the tumor, and these are the tumor vessels. We now have catheters that we can put right here and embolize right from that point and spare the rest of the arteries that may branch off and supply normal liver. So there's really not a tremendous role for preventing the reflux or the non-target embolization, off-target embolization that may have potentially been one of the complications or risks of older technologies. Yes?
For me, the problem always is with patients. I have two kinds of patients. Patients who have a bazillion little teeny tiny things. And then I got people who have 5 or 6 big grapefruits. And I now have spheres, and I now have long-term data, 20 plus years on chemoembolization. How do I figure out who gets spheres, who gets chemoembolization, and do you believe that there's an advantage of what I was talking about, stacking, that you can do one and then you can come back in with the other if you fail? and not necessarily vice versa?
Yeah, there's a lot in there.
I guess that was the question.
And I'm a little bit biased because I trained at a place in the city at Memorial Sloan Kettering, and they are firm believers in bland embolization. And I think we have to, if we're going to practice evidence-based medicine, if we look at the evidence, and I talk a little bit about it, depending on what kind of tumor you have, if you have a carcinoid, you're actually, there is literature from MD Anderson and other places where the chemoembolization is worse than bland embolization. And we know from other studies that chemoembolization may benefit in certain tumor types. There is not a lot of literature and no randomized controlled trials, and this is one of the problems in interventional radiology in all treatments, whether it's hepatocellular cancer, different types of therapies. We don't have great clinical trials, and that is something, that is a movement I think that our society is seeing. If you look at the spheres, there are a smattering of case reports, but the largest series, I'm not sure, they probably know in the back, maybe 40 patients or 43 patients. Most of them are case reports of 9 patients, 6 patients, 5 patients. So we don't really have strong evidence about which to use. But we do know that we probably have the most literature on bland embolization and chemoembolization, and I think we're able to tease out different tumor types that might do better with certain agents.
Does one preclude the other?
No, one does not. You can come back and you can continue to do things. The problem with these tumors is, even though, and we have done multiple rounds of embolization, even though you block these up, these particles are not permanent. And tumors in general can recruit new blood vessels that have to be re-embolized. So there is a role for multiple treatment sessions, and the way we do it is it may be as frequently as every 6 weeks or 2 months, or it just depends on, and we monitor it with imaging, CAT scans, MRIs, Artery scans. I'm not sure if that answered that. But it's a very complicated, it's a very difficult question, and I think we're moving towards that, but there are no great clinical trials. No, the patient population is not big enough, and everything is so spread out. Question?
Are you outpatient?
No.
How long you stay in?
Well, everyone is different, but I tend to want to keep you in the hospital at least 1 or 2 days.
Can you want to define particles? I mean, particles meaning which? Beads? Is that a particle?
We have beads, which are particles. They are calibrated microspheres. They're plastic particles. We have PVA, which is polyvinyl alcohol, also are particles. We tend to be moving more towards the bead therapy with or without chemotherapy. And these beads are calibrated, and the particle size that we use in the liver are anywhere between 100 to 500 microns. Each bead is 300 microns in size.
Bland beads embolization as opposed, is there something that is considered radioactive?
There are, and that's the yttrium, which I'll talk briefly about in a little bit.
Craig, I know you have a lot more to go.
Yeah, no, sure.
There was a slide you showed
Yeah.
before with 4 different livers.
Yes.
4 different
Right.
types of mets.
Right.
So I just want, maybe if you could tell the people in the audience, right, which one of these can you do, which ones can you not do, which one would you prefer surgery, which one would, how do you choose what's an appropriate
Yeah.
liver for you to work on? And maybe, Gene in the back.
Yeah, maybe Dr. Waltering can comment on the surgical.
Or maybe Richard knows.
Yeah.
Has a different opinion on what to do.
But if your liver was the one on the top and that was your only lesion, you may be a candidate for surgical resection. If your liver is the one on your top right or bottom right, you may be a candidate for a liver transplant, like some other people. And if your liver is the one on the bottom left, well, that one's potentially a problem because that is a very large tumor. It's occupying potentially more than 50 to 70% of the liver. And in very large tumors, we have learned that if you embolize those particularly very large solitary tumors, the risk of infection and abscess formation goes up and could make things worse. So that's one of the things. But because we can be super selective now with catheters, we could potentially embolize even very large tumors in a staged fashion and try and minimize the risk of those complications.
Is there a number of lesions that you would say you can't, like the one in the top right, those miliaries?
Yeah.
You couldn't really do that.
No, we could. And we would do, even the diffuse bilobar disease, we would do in a lobar fashion. We would block up just the right hepatic artery, leave the left hepatic artery, and then come back in 6 weeks and do the left hepatic artery. So diffuse disease involving both sides of the liver can be done embolically. Yes?
As a caregiver of patients with neuroendocrine carcinoma, islet cell, how does she, you said patient selection is critical as to whether they are a candidate. Who does she go to decide if she is a candidate? Can she go to a radiologist?
She can, yeah, I'm sure through the medical oncologist and the person, she can get plugged in and see us. If there's someone outside, yeah, you can. We consult with patients directly. We review the imaging. We review all the laboratory work to see if they're candidates and if they can tolerate it. Yes?
If you have multiple lesions, do you, and these lesions are throughout the liver, you would expect that it would be in the rear of the liver. Can you get to that with your catheter into the rear of the liver?
Yep, we can go anywhere within the liver. Yep. Okay, so this is, I think this is where we were. And we talked about, so you can see, I think it's very obvious that you can see, this is an angiogram, a hepatic angiogram, where we put a catheter in the artery that goes to the liver. And this is a reasonably normal hepatic arteriogram. This is abnormal, and you can see the blood vessels from, that supply the liver. This is a tumor. You can see these black splotches, the puddling of contrast within the tumor, and you can see it up on top, the same thing. So we would navigate catheters using the X-ray guidance directly into the blood vessels that are feeding those tumors, and we can inject these particles. Post-embolization, after the procedure, you're admitted to the hospital for pain management, the post-embolization syndrome. We monitor your liver function tests. We would get a CAT scan on day 1 and then at a month. And then we go from there and figure out, you know, when you potentially need to come back. This is potentially what can happen after embolization. You can see on the top CAT scan, large tumors in the left and the right lobe of the liver. And after embolization, basically, you can see the shrinkage. It's mostly focused on that right-sided tumor, and we can shrink down and downgrade and downstage potential patients. So, getting back to some evidence-based medicine from the MD Anderson cancer experience in 123 patients, what they found, and again, literature is all over the place. Different groups have found different things, but in this group with a pretty large experience, they found that carcinoids overall do better than islet cell tumors. Chemoembolization, as I mentioned earlier, it did not benefit patients with carcinoid. Bland embolization works better. Chemoembolization does benefit patients with islet cell tumors. And when they compared different groups of chemoembolization or bland embolization, neither really conferred significant survival or progression-free survival. So that's how we can try and figure out what to do. Neuroendocrine tumors, the ablative therapies, the theory is that by decreasing the volume of viable tumor or preventing new growth may lead to longer survival. So we have different tools in our toolkit, and we have something called RFA, or radio frequency ablation, and cryoablation. Again, two ends of the spectrum. They basically do the same thing, and they kill tissue. As of yet, again, the literature it's evolving, but it's still very young. It has an undefined role. It's used to treat smaller tumors. So if you have fewer than 3 tumors in the liver that are each less than 3.5 centimeters, there could be a very important role for one of these ablative therapies. And it can be an adjunct to embolization and surgery. And again, that's why it's very patient-specific. Depending on what your liver looks like, different treatment options are available. So what is RF ablation, or radiofrequency ablation? Basically, an electrode is inserted directly through the skin into the liver, into the tumor, and we use CAT scan or ultrasound guidance. Then we attach this probe, which is in the tumor, to a box which delivers high-frequency radio waves, which causes frictional heat generation. And we heat the tumor over a period of time, and that thermal energy results in temperatures that result in tumor destruction. So if you had one of those livers with 75 lesions, this is not going to work. But if you had 1 or 2 or 3 lesions and they were relatively small, this can be an excellent option. And here's a schematic. That is the radiofrequency probe. The top image shows first the probe, and then these tines are extruded once we're at the edge and within the tumor. So we would then navigate with CAT scan or ultrasound. We would, just like we do with a biopsy, we just pass a needle directly into the tissue which we're targeting, and then once we get into the tissue, we deploy these tines, and each of these tines is connected and is delivering energy and is heating up the tumor and killing the tumor. Cryoablation, it's the opposite of radiofrequency ablation. Basically, there's alternate freezing and thawing of the liver tumors, and it causes intracellular and extracellular ice formation, which leads to tumor destruction. Basically, what we do is we create an ice ball, and by inserting anywhere from 1 to 5 probes directly into the tumor, and then again this probe gets attached, and through liquid nitrogen the temperature is dropped, and we create very low temperatures that also basically results in tumor destruction. And radioembolization. There's an agent called yttrium-90. It's basically distributed just like we would with the beads and the chemotherapy and the chemoembolization. There's vascular distribution. It's a pure high-energy beta emitter of radioactive microspheres. There's a limited, but there is a growing experience with this in neuroendocrine tumors, and it'll be interesting to see what happens as time goes on and more of it is used. But there are still a lot of questions. Do we perform these embolizations early or late in the disease? How much do we embolize at each session? What role does radiofrequency ablation, cryoablation, yttrium-90 play? And these are things that I think we're moving towards and trying to answer. And each patient probably will get patient-specific therapy depending on their tumor type, their stage, and their degree of involvement in the liver. But in summary, these tumors they're a rare group of cancers. They're best cared for in a multidisciplinary fashion with medical oncology, surgery, and interventional radiology. Surgical resection, embolization, and/or chemoembolization, radiofrequency ablation, and chemotherapy will provide patients with improved quality of life and prolonged survival. And liver-directed therapies provide effective palliation, but careful patient selection is critical. Thank you.